Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. In our usual time, Wednesday, 9:30 p.m. And I am so pleasured today to have our great speaker, my dear colleague and friend, Professor Hani Wadei from Mayo Clinic, USA. Professor Hani is an associate professor of medicine in Mayo Clinic, College of Medicine. He holds a joint appointment as a consultant transplant nephrologist in the Transplant Center and in the Division of Nephrology and Hypertension in Mayo Clinics, Florida, USA. Dr. Wadei obtained his medical degree at Cairo University, Egypt, and he completed 2 years of internal medicine residency at Cairo University hospitals before moving to the United States. And I am to mention here, we started our residency together in the same year and in the same section, and we spent these 2 years together as residents, and before he took his track in USA, and I completed in Egypt. He's one of my friends and old friends and colleagues. In the United States, he completed his internal medicine residency at Sinai Grace Hospitals, Wayne State University in Detroit. Dr. Wadei completed his nephrology fellowship at Harper Hospital, Wayne State University, 2000 and before moving to Mayo Clinic, where he completed a transplant nephrology fellowship. He is a fellow of American Society of Nephrology and American Society of Transplantation, and authored multiple papers and book chapters in the field of nephrology, hypertension, and kidney transplantation. And his main focus is studying kidney dysfunction in patients with hepatic cirrhosis and liver transplant recipients, and is studying indications and outcome of liver kidney transplantation. And because of this, we are pleased to have him as a speaker today in one of the important topics: how to optimize diuretic therapy in patients with liver cirrhosis, how to use diuretics and get the maximum desired benefit, avoiding so much hazards from using diuretics. We cannot find better than Professor Wadei to speak about this topic. So please, Professor Hani, start your lecture, and we will come again to after the end of the lecture for the discussion. Start, please.
Thank you, Yasser, for a wonderful introduction. And as Yasser mentioned, yes, we were colleagues at Section 31 in Ascites. I still can remember. I just want to tell you that without the hands-on training I had in Ascites, I would never had the chance of succeeding here in the US. You guys have great teachers, you have great professors, you have great experience with all the hands-on and dramatic amount of work we were doing in Ascites with limited resources, but we were in many situations trying our best to gain knowledge, our best to use the resources we have, and all for the sake of the patient. So I'm very thankful to the time I spent there. With that in mind, and me seeing all the GI bleeding patients in Esmeseta, and having all the memories, I wanted to talk to you about how we can use diuretic therapy and optimize it in patients with cirrhosis. So the slide, I don't know why the computer is acting up a little bit. So we will first talk about what happens in Well, first, I think it has something to do with the mic. We'll work with this. I don't know. We'll have to talk first about No, what's the problem? Perfect. So the layout, we're going to first talk about what happens in hepatic cirrhosis and what are the pathophysiological changes that happens. And we have to spend some time talking about diuretics and how do they work in different pharmacological classes. This part might be boring, but it's going to be very important. And the third part is about talking about the diuretic regimen in cirrhotic patients, what works and what does not work. Number 4 we'll talk about diuretic resistance and how to address that. And I thought the best thing of delivering the message is to prepare some cases. And these cases, some of it I borrowed from papers, some of it I just borrowed from my clinical practice, some of them I just made up, okay? So don't quote me on minor details, but each case has a message to deliver. So what happens in cirrhosis? What happens? I don't know what's happening here. Happen. So what happens in cirrhosis per se is that the whole I don't know why it's doing this. It never happened before. Coding. Okay. So what happens, pathophysiological changes in hepatic cirrhosis, is that the problem starts with the liver. There will be distortion of the liver structure itself, will prevent the outflow of blood to the systemic circulation and will cause portal hypertension. This is along with the increase in nitrous oxide, which is a vasodilating substance, will cause strengthening vasodilatation. So the circulation pretty much will be stolen from the systemic side to the portal side, which will create a situation of reduction in the effective circulating volume. So the baroreceptors in the carotid in the carotid and other pressure sensing receptors in the body, like the renin-angiotensin system and the posterior pituitary gland, will start acting like this patient is dehydrated and dry and need to preserve volume. So the renin-angiotensin system will go sky high. Because of the baroreceptor activation, the sympathetic nervous system will go sky high. Non-osmotic release of vasopressin will happen as well. And all this are aiming to create a situation of vasoconstriction to maintain the circulation in an appropriate level. And what happens is with time, the renal vasoconstriction wins and it goes to the kidney, cause proximal tubule sodium retention, decrease capacity to excrete solute free water because the circulation to, or the flow to the distal nephron is limited. So this will cause free water retention. And with the free water retention, hyponatremia will happen. And because of all this, there will be decrease in the GFR and increase in the creatinine. Just want to impress upon you that this does not happen overnight. So I'm not touching the computer and it's just acting like this.
Okay, you can process.
So we talked about the liver cirrhosis causes effective circulating volume depletion, activation of the sympathetic nervous system, non-osmotic release of vasopressin, and activation of the renin-angiotensin system. And the end result is intense renal vasoconstriction and increase in sodium absorption in the proximal tubule, decrease free water excretion, hyponatremia, and eventually drop in the GFR and increase in the creatinine. But I want to tell you, this does not happen overnight. It takes a while for it to happen. So with the start of cirrhosis, there would be a phase called compensated cirrhosis, which the ascites might not be even there. So nobody knows that the patient has cirrhosis, no peripheral edema, nothing. But in the background, there is some changes happening. There is increase in the splanchnic vasodilatation and slight drop in the systemic vascular resistance. As the disease progresses, ascites start to appear. And initially, the first stage of ascites we call diuretic sensitive ascites, because you give diuretics at this stage, and the diuretic works and eliminates the ascites and eliminates the lower extremity edema. During this phase, there is still gradual deterioration in the pathophysiology with increased extra splanchnic vasoconstriction, means renal vasoconstriction, continuous rise in the degree of renin-angiotensin system activation, sympathetic nervous system activation, and continuous increase also in the splanchnic vasodilatation and reduction in the effective arterial volume. Eventually, at the terminal stage after that, there will be the ascites called ascites diuretic resistant ascites or refractory ascites. You give diuretics at this stage, and it does not work. And this stage, right, happens before what we used to call type 2 hepatorenal syndrome, which is rising creatinine in association with all the pathophysiological changes you're seeing. So rising creatinine is a late event. Many times it's preceded by refractory ascites where diuretics don't work and you need to do paracentesis. And at this stage, there is intense renal vasoconstriction, maximum activation of the renin-angiotensin system and the sympathetic nervous system, severe dilatation of the splanchnic circulation, and even in the effective circulating volume is the minimum, and cardiac output to start to drop. So this can take 6 months, can take 6 years. So it depends on what disease state we are talking about and what caused the liver cirrhosis from the first place, and whether it's a continuous insult. Like if somebody with alcoholic hepatitis, for example, or alcoholic liver disease, and they continue to drink alcohol, this is not going to take more than 2 years. But if they stop and start and stop and start, it will take longer. If they stop completely, it might even be controlled, especially in the case of the alcoholic liver disease. So what happens when there is excessive systemic vascular resistance and decrease in the systemic vascular resistance and decrease in effective circulating volume, that hypotension will start to manifest. And here, with the splanchnic vasoconstriction, extra splanchnic vasoconstriction means renal vasoconstriction, there will be progressive increase in sodium retention. So I want to impress upon you, this is not an on and off switch. It's a progressive disease. As the disease progresses, more salt retention will happen, more ascites will happen, and to the point that diuretics initially will start to work, but later on the diuretics will not gonna work. So what is the mechanism of ascites in cirrhosis, and what are the mechanism of salt and water retention? First, there is a stage where even there is none of these pathophysiological changes, what they used to call the hepatorenal reflex, where because of the liver disease itself, the kidneys start to retain sodium, and the stimulus of this is unknown. So there is, in animal studies, early cirrhosis, before ascites even start to develop, renal sodium retention is increased. We talked about the rest of the mechanisms: portal hypertension that causes ascites, decrease the effective circulating volume, cause more renal and sodium retention, and the vasodilatation, decrease effective intravascular volume, renal sodium retention, and the result is increased extravascular volume or extracellular volume, and ascites will start to develop. After the ascites develop, if you don't treat it, edema, peripheral edema will develop. So the recommendation is, and this would be useful later on, is every time, first time you diagnose somebody with ascites and liver disease, is that you have to do diagnostic paracentesis to calculate the SAG, which is the serum albumin to acidic fluid gradient. And if this is above 1.1, you got ascites because of liver disease. If it's below 1.1, that's something else: peritoneal disease, tuberculosis, or anything else, peritonitis, anything else, not liver disease. Above 1.1, you can further divide it based on the acidic fluid protein, not acidic fluid albumin. The total protein is acidic fluid. Below 2.5, that's pure hepatic cirrhosis. Above 2.5, that's post-sinusoidal. And we see it often in the cases of cardiac cirrhosis, for example, and in people who have like Wadei syndrome or post-sinusoidal cause of the portal hypertension. So it's very important to do this because you want to make sure that whenever you're going to use diuretic on somebody, this ascites is because of the liver disease, not because of something else. And also the ASDAD, which is the American Association of the Study of Liver Disease, published this sentinel paper, and they keep updating it every 10 years. Last time it was updated was in 2023, and they graded ascites, and based on the degree of the ascites and based on the response to diuretic. So mild ascites is grade 1, and this can be fully mobilized with diuretics and low sodium intake. Grade 2 ascites, moderate ascites, it's on recurrence. You're taking the diuretics, it's improving the ascites, but at some point you have been requiring paracentesis, but still the diuretics are working. Stage 3 ascites, which is refractory ascites by definition, and at this stage, diuretics don't work, okay? And there is no benefit of giving them because they will cause more problems than benefit. So covering the pathophysiological changes with cirrhosis, I want to talk a little bit more about diuretics. And it's very important for any nephrologist to know all diuretics because cardiology have multiple different classes of medication, antiarrhythmics, antihypertensives, all kinds of medications. Oncology have lots of medication. We nephrologists, diuretics is our bread and butter. So we need to understand what is diuretics quite well. And we know that diuretics work by getting salt out of your body. Natriuresis, it's not because volume increase. It increases first of all salt secretion. Negative salt balance is an aim. Once you achieve negative salt balance and you achieve natriuresis, the water will follow by osmosis, and the urinary water excretion will go up to achieve a net negative salt and water balance. So this is the concept about diuretics. You can use it in multiple different situations of extracellular volume excess. People call it volume overload, but we nephrologists call it extracellular volume excess, like hepatic cirrhosis, congestive heart failure, nephrotic syndrome, and even in renal failure. You can also use diuretics to treat other conditions. Most commonly is hypertension, for sure. So it's very important to understand the pharmacology of these medications. And as a general rule, some of them will be well absorbed. Some of them won't be well absorbed from the GI system. So bioavailability is variable. We need to know what is the primary site of metabolism of each one of them, because that helps us with the management of patients, not only in cirrhosis, but all the patients we take care of. These diuretics are heavily albumin bound with very minimal portion, which is free. And this free portion, which is free, it does not do anything. The part that does the work is diuretics that get secreted, actively secreted into the tubular lumen in the proximal tubule using the organic anion transporter. And this is the only way of the diuretics reaching the site of action. Probably the exception to this is a mineralocorticoid receptor blocker, spironolactone, eplerenone, and the rest. But all the diuretics had to be secreted actively in the lumen to reach the site of action. So they work primarily from luminal side of the nephron. So if you have low GFR state, low flow to the kidney, blood flow to the kidney, it's gonna be not easy to deliver the diuretics to the site of action. So how diuretics get into the lumen of the kidney? This is a blood side, this is the luminal side, and there is an organic anion transporter here that brings the diuretics in, and in exchange for alpha ketoglutarate, okay, this organic anion transporter is the same one that works on the tubular side, secreting diuretics into the urine. So this is the urine, this is the blood, in exchange for urea. That's why you see a rise in urea with diuretics, because to secrete the diuretics inside, you have to absorb urea back to the bloodstream. This organic anion transporter can be blocked by many things. One of them is probenecid, and therefore, if you give probenecid and Lasix, don't expect the Lasix to work. Other things more common than probenecid we're gonna go over, because it's very common mistake when we use diuretics. So another important concept when it comes to diuretic to understand the difference between IV and PO formulations, and to understand the concept of threshold and ceiling. So threshold is the dose of diuretic or blood level of diuretic below which there will be no effect. So let's say you give somebody 10 milligrams of Lasix, and this does not reach the threshold. There will be no diuresis, there will be no natriuresis. And the ceiling is the maximum concentration of the diuretic beyond which there will be no effect. So you give somebody 200 milligrams of Lasix IV, you exceeded the ceiling. There is no major benefit from doing that other than extending the duration of the Lasix in the system. But the ceiling dose has been already achieved. And this is another important concept, that the volume of distribution affects the threshold at which the diuretic work. So under normal condition, the threshold will be here, low, but with edema, because of the volume of distribution goes up, the threshold of the diuretic itself, the dose at which the diuretic start to work, is much higher. With IV, you achieve the threshold very easy, and it stays above the threshold for just short period of time. So you get enough diuresis early on, but down the road, it's not effective. While with PO formulation, it's slowly progressing, achieves the threshold, and slowly going out below the threshold. So you get longer duration of action, but not as effective. So the point I want to make here is Lasix 40 milligram IV twice is not equivalent to Lasix 80 milligram IV once, okay? Because if you do this twice, you will completely cover the longer duration, achieving that natriuresis over a prolonged period of time. But if you give it only once, what's going to happen is that it will work for 6 hours, and after the 6 hours, the kidney will start retaining salt again. So you kind of did not do much. So to better understand diuretics, we have to understand first how the kidney handled the sodium. So as we all know, GFR is here in the glomerulus, and most of the sodium, as anybody else, get reabsorbed 65% of it in the proximal tubule. Fine-tuning happens in the rest of the kidney. Main part is the thick ascending limb because 25% of the sodium get absorbed here. The rest, so 25 and 65, that's like 80%, 90%. The rest of the 10% is in the distal tubule, 5, and collecting duct around 5%. So the fine tuning happens proximal, most of the absorption, but anything can work proximally, the distal will oppose it. So that's why diuretics that works on the proximal tubule is not very strong because the distal tubules will oppose the action of what it did proximally. The most potent diuretic we have is the one that works at the thick ascending limb, which is loop diuretics, because this blocks 25% of the sodium, and beyond which only 5 to 10% of the sodium is handled. So you can do a good job natriureting somebody just by using loop diuretic only. Again, I want to impress upon you that the kidney is smart, and we have basic intuitive pathophysiological mechanism to us. And every time there is a drop in pre-renal blood flow, any time there is drop in the renal blood flow, all what the proximal tubule does, thinks that you're dehydrated. And all what it does, it retains all the salt it cans. And again, that's what exactly happens in cirrhosis, especially late stages. Progressively increase in the proximal sodium absorption. So this is an overlook of the nephron and where the sites of diuretic work. So the proximal tubule, carbonic anhydrase inhibitor is the main diuretic that works on the proximal tubule. It works by blocking the sodium hydrogen ion exchanger, preventing absorption of sodium in the proximal tubule. Okay, we're going to go over each class later on in full detail. In the thick ascending limb, loop diuretic is the main one, and it works by blocking the sodium potassium 2 chloride channel, which is responsible for 25% of the sodium absorption. In the distal tubule, sodium chloride channel is blocked by thiazide diuretics, and again, this is responsible for 5% of the sodium. And the last fine tuning is with the ENaC channel, epithelial sodium channel. This is a very tricky channel because beyond which there is nothing that controls the sodium, and beyond which there is an open word. You cannot do anything after that to control the sodium excretion. This ENaC channel is controlled by mineralocorticoids, which have its own mineralocorticoid receptor, which is intracellular, and it's also controlled by direct inhibition from medication like amiloride and trimethrin. You see here that the sodium goes in exchange for the potassium. So every time you see hypokalemia in any patient, you think about this channel because this hypokalemia and hypertension, you think about this channel. Absorbs sodium, secretes potassium, especially if there is also metabolic alkalosis. But this is just in general terms, not related specifically to cirrhosis. So this is a very tricky channel. 5% of the control, but it's very important because this is the last ditch beyond which you cannot do anything. So let's go one by one. Carbonic anhydrase inhibitors, widely expressed enzymes in many tissues, including the kidney. In the kidney, there is isoform 2 and isoform 4. Isoform 2 is intracellular. Isoform 4 is luminal bound outside in the brush border here of the lumen. And it's responsible through multiple different reactions, as you can see, and eventually it controls the sodium hydrogen channel. which is responsible for sodium absorption in exchange for hydrogen ion. So if you block this channel, you're going to have metabolic acidosis or have a form of Fanconi kind of syndrome. So well-known medication of this class is acetazolamide, also known as Diamox. As we mentioned earlier, because it works in the proximal nephron, it's very weak because distal nephron will compensate. But there is times that we might need to use it. Side effects, hypokalemia, as most of the diuretics. It can, by blocking the hydrogen ion secretion, will cause non-anion gap metabolic acidosis and alkaline urine. Alkaline urine will precipitate calcium and phosphorus together and cause kidney stones in certain, if you use it for too long. How relevant it is in the cirrhotic patients? Not much used unless there is significant metabolic alkalosis. What about the other class, which is a class diuretic, is a loop diuretic? Again, work in the thick ascending limb, sodium potassium 2 chloride channel is blocked. 25% of the sodium absorption happens here. It's very potent diuretics. Many medications have been described, like furosemide, Lasix, bumetanide, Bumex, and torsemide. And we'll go over some of the differences in the pharmacology, but we understand that this as a class is very potent diuretic. It has also a unique action in terms of blocking the sodium potassium 2 chloride channel in the macula densa. It disrupts the tubuloglomerular feedback and maintains the GFR. So you don't see much fluctuation in the serum creatinine with this kind of diuretics. It will happen. Creatinine will increase, but not at least initially, till at least you mobilize a significant amount of the edema. It's very potent, but there's side effects, of course. Hypokalemia and metabolic alkalosis is very common, especially in cirrhotic patients who are predisposed to that. And hypokalemia in cirrhotic patient is bad because it causes hepatic encephalopathy. So, or precipitates hepatic encephalopathy. So you want to be very careful using this diuretics in the setting of liver disease. Hypotension with IV use. Because of the metabolic alkalosis, it will activate the intrarenal inside the kidney, renin-angiotensin system, and across autocrine release of angiotensin that goes to the ENaC channel I talked to you about in the distal nephron, causing it to be activated or get the aldosterone working through the mineralocorticoid receptor, again in the collecting duct in the distal nephron, to retain more salt. And that's why there would be something called diuretic breaking phenomenon. It works, but somehow at some point it stops working. Okay, why? Because there is more activation of the ENaC channel in the distal nephron. Hypernatremia is common in this with the diuretics, mainly because it affects the concentration of the interstitium of the kidney, allowing more free water to escape in the urine, and then you will develop concentration hypernatremia, basically. Ototoxicity is very common when you use it at a very high dose, and if you combine it with medication like aminoglycosides, hypocalcemia can happen too because it blocks the paracellular absorption of calcium and magnesium. So hypocalcemia, hypomagnesemia will happen with this class of medication. The other important class is thiazide diuretic. It works in the distal convoluted tubule, blocking the sodium chloride channel. And that's an important channel that regulates. It's very important when management hypertension that we need to block this channel. Many different drugs has been used. Hydrochlorothiazide, its brother, chlorthalidone, which is orally as well, but available. It's a very long-acting. Metolazone works good in people with low GFR because partially it does not need luminal secretion. It can work from the blood side, the same as mineralocorticoid receptor blocker, and indapamide. In general, they're weak, but works very good with the loop diuretics and works very good in controlling blood pressure. Side effects is lowering the blood pressure, as any other diuretic, hypokalemia and metabolic alkalosis. It will raise the creatinine. Every time there is used hydrochlorothiazide, especially in situations where the kidney is vasoconstricted, it will cause activation of the tubuloglomerular feedback, decrease renal blood flow, raises the creatinine. Hypercalcemia and hyperglycemia are also common side effects from hydrochlorothiazide. How often do we use hydrochlorothiazide in cirrhotic patients? Not very often. We use it only if there is associated hypertension. The Cadillac of diuretics in cirrhosis is the potassium-sparing diuretics, which again works on the distal collecting duct, ENaC channel here, epithelial sodium channel, which absorbs sodium in exchange for potassium, controlled by the mineraloreceptor, okay, and activated by aldosterone, which, as we said, is very high already in patients with hepatic cirrhosis, and causes mineraloreceptor to be activate the sodium channel, cause sodium retention, and then edema. This is luckily blocked by medication like spironolactone, while the ENaC channel is directly blocked by amiloride. So you can divide potassium-sparing diuretics into two. One ENaC blocker, like amiloride and permethrin, and one mineralocorticoid receptor blocker. We have spironolactone, eplerenone, and phenyrenone. Spironolactone, believe it or not, although it's cheap, it's the most potent, most effective, more effective than eplerenone. And phenyrenone is approved for in patients with CKD. I never used it in somebody with liver disease. So either we use spironolactone or eplerenone. Because they act at the distal nephron, it can cause hyperkalemia by preventing potassium secretion. And they do also have the side effect of gynecomastia and impotence, especially with the spironolactone. The others don't have this side effect. We cannot finish a talk about diuretics without talking, we cannot finish a talk in nephrology in general without including SGL2 inhibitors. And SGL2 inhibitors work on the proximal tubule, preventing sodium absorption exchange for glucose, which is a weak action. It's not strong, but they also block sodium hydrogen exchange same way as the carbonic anhydrase inhibitors. So they do have a weak diuretic effect, at least at best, by causing natriuresis. But this is not what I wanted to impress upon you. Okay, so they have a natriuretic effect. But what I wanted to impress upon you is their effect when you combine them with loop diuretics. So this is a study by Dr. Wilcox, who was a famous doctor who studied diuretics extensively. And if you want to search any topic about diuretics, just search his name. So he did patients, two groups, patients who were on Bumex for 1 week. Then he gave them DAPA afterwards. And as you can see, there is increase in natriuresis, sodium excretion. And the other group, they give them the DAPA first and followed by Bumex. And DAPA on its own causes mild natriuresis, but when you combine it with Bumex, there was excessive, a significant increase in the sodium secretion in these patients. So I'm not going to talk anymore in this discussion about SGLT2 inhibitors, but I just wanted to tell you that because diabetes is rising, obesity is rising, NASH cirrhosis or MASH cirrhosis, now they call it, is rising, you will see patients coming to you already on SGLT2 inhibitors. And if you're going to give them Bumax or Lasix or any other diuretics, you just have to be mindful of the synergistic effect. This slide is very important. And if you want to take one slide out of this whole deal, this is it. This is the slide that you need to take. Because nephrologists are very smart and they need to know this like the back of their hand. So loop diuretics come in different flavor. They're not all the same because they have different bioavailability and metabolism. So Lasix, for example, furosemide, only 50% get absorbed. If you're going to give it IV, if you're going to give 40 milligram IV, 40 milligram would be delivered into the circulation. But if you give 40 milligram oral, only 20% would be delivered to the circulation. So you have to be mindful. The medicine is metabolized primarily in the kidney, and some of it is secreted in the urine unchanged, but zero metabolism in the liver. That's why in patients with chronic kidney disease, the half-life is prolonged from the normal 1.5 to 2 hours to doubling that. In other conditions too, because of multiple other things, the half-life is prolonged as well. You have to differentiate between half-life and duration of action. So half-life is the time needed to metabolize 50% of the medicine. So half-life is 1.5 to 2 hours, double that in CKD and double that in end-stage liver disease. Bumax is different, 100% bioavailable. 40 milligram of Lasix will be equivalent to 1 milligram of Bumax, 50-50 as far as hepatic kidney metabolism. That's why its half-life is not affected much in the CKD population, but in the liver population, it's a little bit prolonged. Furosemide is my favorite because it's 100% bioavailable, mostly metabolized in the liver. It's a very long-acting. So I like it because 20 milligram or 40 milligram of furosemide lasts almost 12 hours, causing natriuresis, which is a great thing to have in people who cannot control their salt intake. Thiazide diuretics pretty much have the same bioavailability, around 70%. This is the equivalent doses, mostly metabolized in the kidney. Half-life is longer with a chlorthalidone. Metolazone has some hepatic metabolism, and half-life is intermediate between hydrochlorothiazide and chlorthalidone. The distal diuretic, you have also to understand them. Amiloride, 50% of it get absorbed and 50% of it gets secreted in the stools unchanged. At 10 milligram amiloride, it would be equivalent to 40 milligram of Lasix. And has long half-life that is prolonged in CKD because this is the only place it gets metabolized is the kidney. Amycretin is tricky. 80% get absorbed because it does not really get secreted in the stools, but it gets metabolized mainly in the liver, and it gets metabolized to an active drug. So amycretin is a prodrug, it's not an active drug, and it gets activated in the liver. That's why it really does not work that well in people with cirrhosis because you need hepatic activation of the medicine. Aldactone, 100% metabolized in the liver, almost 100% bioavailability, long half-life, and not affected by kidney function or liver function. So it is a good diuretic to use, but we know that it causes hyperkalemia and we have to monitor it. So now we covered quite a bit. We covered the pathophysiology in cirrhosis. We covered the diuretics and how do they work in different classes. We covered the different pharmacological properties.
we want to know now that our goals in cirrhosis, how to address, how to handle diuretics. So diuretics is not indicated for everyone. You have to get somebody who has ascites or ascites with edema. So in the pre-ascitic phase, there is no point of giving somebody diuretic. We understand that there is some increase in the salt absorption in the kidney, but it's not needed, the diuretics. It's actually by the ASLAD, it's not indicated. They recommend starting aldactone because, again, the mineralocorticoid is super active, and aldactone will avoid the hypokalemia that causes metabolic derangement, including encephalopathy. So we recommend to start the aldactone at 100 milligram and assess the response. Okay, very important, salt restriction, because I will show you why salt restriction, without it, you cannot really use diuretics because it's not going to work. So 2 grams per day, which is equivalent to 5-gram table salt, okay? And then assess the response. And your target is between 0.5 and 1 kilogram per day weight loss. The edema, peripheral edema resolves, and only there is mild ascites. At that point, which is stage 1 ascites, you can scale back a little bit on the diuretics and see if you can maintain the patient without edema on a smaller dose of diuretic. But if there is no response, increase the aldactone to 200, increase the spironolactone to 200. If there is no response, you can add 40 milligram of Lasix. But some will start the 100 of spironolactone and 40 of Lasix together. So the bottom line that for a diuretic to start working and start, because some of it works intracellular, you need at least 3 to 4 days to see some response. So don't change the dose daily. No point. Maybe it would be best to assess the patient weekly because you need to see if you get 0.5 to 1 kilogram per day weight loss or not. You need to give 3 days for the medicine to work and another 3 days to see response. So maybe seeing the patient once a week or assessing once a week and adjusting the dose once a week will be more practical. Okay, and the maximum dose or the maximum recommended dose of spironolactone is 400 milligram daily and 160 milligram daily for Lasix. And this is, we're talking about oral Lasix, not IV Lasix. So I found this study, which is kind of informative because there was a debate among the hepatology community, which diuretic should we start? Should we start spironolactone first? Should we start spironolactone followed by Lasix? Or should we start both of them together? And in this study, they looked at 90 patients who gave them the 3 different regimens of diuretics. One combination from the beginning, 31 patients. One, they started with Lasix first, and the other one, they started with spironolactone, and based on the response, they gave them Lasix. So you can see here the weight loss on this graph between the sequential treatment, spironolactone and Lasix, Lasix alone, furosemide alone, or combination from the beginning. There is no major difference. If you tell me, I feel like the sequential did better, but the statistics did not show them. And looking at the BUN and the creatinine, most BUN went up with a combination. So the combination was harsh on the kidney. BUN went up. Creatinine went up in all of them, but with the combination and the furosemide alone, there was no difference. What they saw, which I did not include in this slide, hypokalemia was severe with Lasix alone. And to the point that they had to monitor closely the potassium and supplement potassium a lot in these patients. Again, we're giving Lasix in a setting where the aldosterone is activated, so potassium has no chance. It will go down in the urine and hypokalemia will develop. When they looked at encephalopathy or hepatorenal syndrome, there was no major difference between the 3 regimen. So you can choose which regimen you would like, but I personally prefer spironolactone first and add Lasix down the road, which is a sequential regimen here. You cannot do this without help. So to give diuretics to the sick people, you cannot just do the diuretics and let them leave without any monitoring. As we said, we need to see them once a week to adjust the diuretic dose, but we need to give them educational material too. We have to, this is an online calculator, tell you how much sodium in table salt. So each 1 tablespoon of table salt would be 6 grams, will have around 2,300 milligram salt. And that's pretty much the maximum a patient can have in a day. Why not 1,500? It's very hard to achieve 1,500 milligram sodium per day because already 1 tablespoon, okay, or 1 teaspoon, I mean, it's 6 grams. It cannot be that. This is very harsh. You have to tell the patients to follow the labels. I know in Egypt they do that labeling now. So here, for example, whatever product says, it has 430 milligram of sodium per serving. So don't take 6 servings per day because you're gonna be up to 3,000 milligram salt, and then the diuretic is not gonna work. You have to have a scale, monitor the weight, see if are you over diuresing or under diuresing. You have to monitor the blood pressure. Many of this medication can cause hypotension, and we know in the hypotension state, the kidney will retain salt, and then we're doing the opposite of helping the patient. And we have to continue to monitor electrolytes. We cannot put them on diuretics, send them home, see them in 1 month. It will come with a potassium of 2.5 or 6.5. You never know. So you have to monitor this closely, especially when you're adjusting the doses, and see the patient frequently because the disease is progressive. The disease is not static. What is happening today is different what's going to happen 1 month from now. As far as aldosterone activation, as far as the blood pressure, as far as everything. So having said that, we want to move to the most important part here is diuretic resistance. I'm giving the patient diuretics and I'm not achieving a response. Despite maximum dose, the weight is steady and no reduction in edema. I'm not achieving anything. What are the causes of that? First cause is that this is not ascites, as we said before. That's why you need to do the SAG to confirm that this is ascites. But assume that we did this. The other thing we want to address is the salt intake. Why is this important? Because this is a sentinel study done many years ago, looking at people on high salt diet and low salt diet and the response, diuretic response. So people who are on high salt diet, if you give them IV furosemide, their salt secretion or excretion, sodium excretion, will go up tremendously, probably more than the people who are on low salt diet. But continue to eat salt. And between the doses of diuretics, the kidney retains salt they're eating. So we repeat this on day 2, on day 3, and the end result is nil. The natriuresis did not happen because the amount you took eventually balanced out the amount you lost. That's not what happens in people with a low salt diet. With a low salt diet, they don't have that much natriuresis as the high salt, but in between doses, because you don't eat salt, you don't retain salt, then end result is negative salt balance and negative salt and water balance. That's what the aim of using diuretics. So without cutting down the salt, don't say why diuretic is not working. It's working, but you're always working against it. So how to address this issue? Somebody, no weight change on diuretics. We have to address this issue and say, okay, we'll do a 24-hour urine for sodium. And if the sodium excretion in the urine is elevated and no response, as we said, above 8 millimole or above 100 millimole per day, then this person is eating lots of salt. You have to address it with the person and tell him you have to eat less salt. If the urine sodium is below 80 millimole per day, then this is you're not giving enough diuretic. So you need to increase the diuretic, add the different diuretic, use a different formulation which can bypass the gut edema and all those things. You need to do something different, okay? But the condition to do this test is that you have to have normal kidney function, right? Might not be as accurate and as patients with hepatorenal syndrome or things with elevated serum creatinine. You can say it's very hard to do a 24-hour urine collection, get it accurate, especially with people taking lactulose, patients having diarrhea, all the rest. So I cannot do it, cannot obtain the 24-hour urine. You can check spot urine for sodium and potassium. And if the sodium is higher than the potassium in the urine, spot urine, this is that the patient is eating more salt than he should. If the opposite happening, the sodium is less than the potassium, then this is diuretic dose needs to be increased. I apologize for the sign is not correct. So if the sodium is more than the potassium, then you need to address dietary non-compliance. If the sodium is less than the potassium, there is increased diuretic dose needs to be done. You can put a ratio, sodium over potassium above 1, dietary non-compliance. Sodium over potassium below 1, increase the diuretic dose. I just want to tell you that they picked 80 millimole in the urine because 80 millimole corresponds to the around 5 grams of salt already. So, so 80 millimole is equal to 4.7 grams of sodium. What other causes of diuretic resistance? Very important is decreased drug delivery. Gut edema is common in patients with cirrhosis. We said that furosemide has limited bioavailability. So if you're giving somebody furosemide and you suspect it's not working because of gut edema, switching it to bumetanide, Bumex, will be a good idea because it will be better absorbed, higher bioavailability. In certain situations, you have to give it IV to avoid this problem. Infrequent doses of diuretic, that's a very common mistake, okay? Because as we said, diuretics don't cover 24-hour urine, all of them. Some of them do, like spironolactone does, but furosemide doesn't, okay? And that's what happens in the case of furosemide. If you give loop diuretics, furosemide, you will have maximum natriuretic effect that lasts around 6 hours. But after that, depends on your salt intake, there will be a little bit of rebound, increase in the absorption of the sodium by the kidney. Then you give the next dose. And to avoid that, you need to do more frequent dosing. Diuretics twice a day, diuretics 3 times a day to avoid this feedback or the retention of salt after the diuretic effect is done. The other important thing, which is very common in patients with cirrhosis, hypoalbuminemia. As we said, the diuretics are bound to albumin. The active portion is the one that is bound to albumin, gets delivered to the distal tubule, to the proximal tubule, luminal, the blood side, and require organic anion transporter. So if you don't have the shuttle, you don't have the bus that takes the diuretic to the organic anion transporter, there will be decreased delivery. And it also, especially with the furosemide, things that get metabolized in the kidney, it will increase the metabolic inactivation or increases catabolism. So for that, you have to correct the hypoalbuminemia. Some people recommend, well, should we combine albumin with diuretics? Many studies have been done in this. Studies done in heart failure patients did not show any benefit. Cirrhosis is different. some people say it's beneficial, some people say it's not. So it depends on what your practice is. Another important cause for diuretic resistance is, again, decreased drug secretion. As we mentioned that this diuretics to be delivered, it needs good kidney blood flow. So in the case of hepatorenal physiology, there is decreased effective arterial blood volume. The kidney will not have enough blood flow to deliver the diuretic, and as we said, the proximal tubule will absorb most of the sodium, leaving minimal amount of the sodium going to the distal nephron. So the end result, there will be a problem with diuretic management in this patient because there will be progressive increase in renal vasoconstriction, progressive decrease in renal blood flow as the disease progresses. And that means progressive diuretic resistance. So to avoid that, you have to treat really the underlying condition, which is the liver cirrhosis. We talked about the organic anion transporter early and how it gets the diuretics inside the lumen, but there is many inhibitors. Probenecid, I don't even remember I ever used probenecid in my life. But in cirrhosis, free fatty acids, bile acids, organic acids might be elevated. NSAID, so somebody who's taking diuretic and ibuprofen, the diuretic is not going to work. Okay. So, and this is a study here looking at how much combining different kinds of NSAIDs with Lasix reduced the sodium excretion. So this is under placebo conditions with ibuprofen, with naproxen, with Sulindac. All of them caused a reduction in the effect of diuretics because it blocks this channel or compete with diuretic on this channel. The end result, diuretics don't get delivered to their site of action. Another important thing that happens because diuretic resistance is over time, the kidney adapts and what it calls distal tubular hypertrophy. That does not mean that they develop muscles in the distal tubule. No, it's more channels get expressed. So in the distal convoluted tubule, more sodium chloride channels. That this is with normal tubule, this is with prolonged loop diuretic use. More channels, instead of one channel here, more channels will be expressed. Means more sodium will be absorbed in the distal convoluted, in the principal cell, in the collecting duct, and the alpha intercalated cells also in the collecting duct. More ENaC channels will be expressed, and this ENaC again, I cannot tell you how much it's taking. So this can also be a phenomenon causing this breaking effect. So diuretics stop working. We also mentioned the renin-angiotensin system and how it's important in the liver cirrhosis patient, and that's why it's the first line diuretic is the mineralocorticoid receptor blocker or the direct blocker of the ENaC channel. We also mentioned is that if you use Lasix for a prolonged period of time, the intrarenal angiotensin and intrarenal aldosterone level will be going up, causing resistance to loop diuretics on the long run. All right. Another in this table, which I took from a famous article, I did not mention a very important mechanism of diuretic resistance. So I put it separately. And it's proteinuria and nephrotic syndrome. So proteinuria is very common. People with nephrotic syndrome, very hard to mobilize their edema. And for many reasons. One of them is that they're swollen and oral medication does not get absorbed and all these things. But there are more than that. So this table here separates the most important three different mechanisms why diuretic resistance develop in patients with proteinuria. One of them is decreased albumin concentration. We said that the albumin itself is a shuttle that takes a diuretic to its site of action. So if you don't have albumin, then it's not going to get to the site of action. It's not going to work. Decreased albumin 2 will increase proximal secretion. This is what we did say before, but it will increase also the metabolism of the latex. We mentioned this before. So hypoalbuminemia on its own will cause increased metabolism and reduction in the delivery of the medicine to the site of action. But importantly, that once you secrete the Lasix or loop diuretics or whatever into the lumen, there is protein there. Then it will bound to the albumin in the urine itself, and it's not going to work. And the only way to treat that is to try to limit the proteinuria. So in the lumen, instead of being free, able to bind to its receptors, the site of action, it actually binds to albumin, and albumin does not let a free portion, and then there will be diuretic resistance. Another important thing why there is diuretic resistance here, this is recently discovered, is one of the proteins that get filtered is plasminogen. And in the urine, the plasminogen would be converted to plasmin. And this plasmin will directly activate the ENaC channel, causing it to be super active and causes, again, diuretic resistance. So the distal nephron kind of adapt differently, okay? So again, the treatment of this is to use sequential diuretics and to block the distal channel with either mineralocorticoid receptor blocker or amiloride, which is direct ENaC channel blocker. This algorithm pretty much summarizes what we said about diuretic resistance. Somebody has diuretic resistance, no response, check for compliance as far as salt intake, pain medication use, blood volume depletion. If none of that, measure 24 urine secretion for sodium. If it's low, below 80 or below 100, then you know that this person is limiting his salt intake, and we just need to increase the diuretics or combine the diuretics, increase frequency, do something. Then if there's still no response, you add more diuretics, and if there's still no response, you probably need to go intravenously or dialysis or something else, because this is not going to work. You can address some of the issues I mentioned about other medications that compete with it, hypoalbuminemia, and using sequential. The best way of fighting diuretic resistance is to do 2 or 3 diuretics at the same time. So question comes to mind, when to use the IV diuretics? When there is no effect of the oral, when there is emergency situation, somebody with pulmonary edema. Some people advocate IV boluses, some people advocate IV infusion. Again, most of the literature is from the cardiology field, and some of them say, I would say most of them say they're the same. My experience is IV infusion actually works better in the patients with cardiology patients, not necessarily in the hepatic cirrhosis, because the cirrhosis patients are a little bit more fragile. But if you're going to use the infusion, a loading dose is needed, followed by maintenance dose. What else to stop diuretics? When there is rising creatinine and acute kidney injury, we did the study, looked at 2,000 cases in 10 centers who developed acute kidney injury and they had hepatic cirrhosis. And this all got admitted in 2019 to a hospital for management of the acute kidney injury. The most common cause, 44% of the cases, were pre-renal AKI because of excessive diuretic use. So diuretics in cirrhosis is a double-edged sword. It will help you mobilize edema, it will help you get rid of the volume excess, but can cause acute kidney injury. They also have side effects. We mentioned hyperkalemia, we mentioned hypokalemia. But another side effect which is common in the patients with cirrhosis is cramps. They get muscle cramps, sometimes very disabling. I have good success with tonic water, I don't know if it's in Egypt or not because I looked for it and could not find it. Baclofen, that's a muscle relaxant that can help. And some people advocate giving them albumin. What they don't know is that albumin has good amount of salt with it. And pretty much when you give albumin plus minus the salt, the cramps get better. Another important situation where you need to stop diuretics is diuretic resistant ascites, because this is the terminal stage. You give them diuretics, the creatinine rise, and it does not work, does not cause any mobilization of the ascites. So at this stage, it's better to either do large volume paracentesis to manage the ascites, stop the diuretics, give them albumin, 8 grams for each liter of acetic fluid removed, or consider tips if they do not have decompensated liver disease. So that would be the other options for this patient. They might even need tips and some diuretics down the road, but in general, diuretic resistant ascites, you need to stop the diuretics because they're going to cause more problems than benefit. So now is the last part of the talk is about cases presentation. Again, some of this I made it up, some of it I copied from publications, some of it are real cases I saw myself. So case one is a 55-year-old gentleman who had hepatitis C that was treated, and the hepatitis C gave him hepatic cirrhosis, but the cirrhosis was compensated. It means that he's not having much ascites. But because of the hepatitis C, he had MPGN. With the treatment of the hepatitis C, we're able to give him some IV steroids, and the MPGN kind of went in remission. Now he is maintained on spironolactone, Bumex, 1 milligram per day, and losartan, 100 milligram daily. Creatinine is not the best, but it's stable with a GFR of 37. He has low-grade protein in the urine, around 800 milligram per gram. And all of a sudden, this patient presented with a rise in creatinine, a rise in blood pressure, lower extremity edema, dyspnea, and ascites. Weight increased by 20 kilos over 1 month's duration, and his GFR dropped to 18, creatinine went up to 3.9, serum albumin is 1.8, his urine has 14 grams of protein, and urine sodium is elevated or not low, let's put it at 14. So my question to you, and I need to hear your answers, please. Why he developed worsening edema? And the question number 2 is how best to manage this patient. We have 26 participants. I'm sure somebody can take a shot at it.
We will see if you have any response. I think they were not ready to be answered. From Dr. Mohammed Al-Diremi, MPGN relapse, one answer.
Okay, that's perfect. So he had clearly MPGN relapse. But why he developed edema? That's why he developed proteinuria.
Hypoalbuminemia, Professor Manan Al-Deep, proteinuria causing diuretic dysfunction. All are these answers.
Why he developed the edema is because of the number 1, worsening GFR, no delivery of the medication, more salt retention. Remember, the kidney is responsible to handle the salt. If you have no good kidney function, maintaining the same diet, you will retain more salt. So worsening GFR, medication is not being delivered, more salt will be retained. Number 2, proteinuria and hypoalbuminemia, as we said. Hypoalbuminemia will decrease the delivery of the medicine, but proteinuria, it binds the Lasix and diuretics in the lumen, prevent it from binding to its receptors. And again, as we said, you can never exclude diet because we eat, we don't know typically how much sodium we're taking. And as again, with the worsening GFR, what you eat before of salt is not gonna be handled with the current GFR today. So you need to cut further the salt intake. So that's good. So how best to manage this patient? Okay, I will take a shot at it. And I think this patient now, given the situation he's in, I don't think, especially with the dyspnea and the 20 kilos weight gain, I don't think oral diuretic is gonna work. So we need to reverse to IV diuretics, escalate the dose. You might even give him IV infusion if you would like. You have to maintain a low salt diet. And once you get the dyspnea resolved and the edema mobilized, you can switch him to oral medication, but at higher doses, okay? But the bottom line, if you don't treat the nephrotic syndrome, and
Hani, some question, some answers about using albumin in this patient from Dr.
yes,
Muhammad and the others.
let me look in the chat.
They are giving answers about giving albumin in addition to diuretics.
Yeah, so that's what we said. Albumin, some studies said it worked, sometimes some studies said it doesn't, okay? But depends on your situation. Albumin itself is salt in it. And the salt content of albumin is the same as 0.9 normal saline. It's around 147, 148 milliequivalent per liter. So I don't object to give albumin. I always object to give oral diuretics in this patient because they need the IV diuretics and they need it fast because otherwise they're going to have problem with the breathing and we might need to get intubated. So there is Dr. Muhammad El-Duremi said IV albumin, IV diuretics, IV steroids, and all answers are correct. That's what he needs. Plasmapheresis, actually, that's what happened to this patient. We give him pulse steroids, plasmapheresis, IV steroids, and that's a patient I took care of many years ago. So that's what, eventually he got even rituximab. And his nephrotic syndrome improved with that, and that's how we were able to treat the cause is here. But thank you for your responses. That makes it very interactive. But that's what happened to this patient. He got IV steroids, plasmapheresis, and rituximab, and his nephrotic syndrome responded. Okay. Case 2, a female lady with type 2 diabetes and hepatic cirrhosis from NASH. Years ago, she started to have some ascites. Hepatologist started her on Dactone 100, furosemide 40. But over the years, she achieved response, but progressively, we had to increase the dose to manage her edema and ascites. Now she's on 300 milligram of spironolactone and Lasix of 40, okay? But you are seeing her because her creatinine starts to rise. Edema is not a problem, ascites is not a problem, but her creatinine is a problem. You look at her labs, creatinine increased from 0.9 baseline, 1.6. Sodium is low, no proteinuria, urine sodium is below 10. You examine her and there is no edema. Blood pressure is low and has no tense ascites. So the question, what is the next step in managing this patient? And I will be looking for your answers, either in the chat or person.
Write your answer, please. Yes. Having overdiuresis.
Okay, Dr. Nawaf say having overdiuresis. That's correct.
Okay.
So what you gonna do? Stop diuretics. Perfect. So
Sure.
it's hard. It's pre-renal. That's correct. So that's what you need to do. Stop diuretics. Give IV fluids and maybe IV albumin. Monitor weight and creatinine closely and don't resume the diuretics till the sodium had improved, the creatinine came back to baseline, and you probably need to lower the diuretics in this patient. Whatever she was taking, the 300 milligram and 40 of Lasix caused overdiuresis. So at this point, if you're gonna correct her acute kidney injury, correct her hyponatremia, you can resume oral diuretics, but it has to be at a lower dose. I hope these cases are useful. Case 3. 51-year-old gentleman with hepatitis C and cirrhosis. Just 6 months ago, started to have ascites and lower extremity edema. Started on aldactone, 100 milligram a day with low salt diet, but he had limited response. Saw his doctor 2-3 weeks later, increased his aldactone to 200, and he had wonderful response. Edema resolved. He is sure that his sodium is low. Then he developed gynecomastia, painful gynecomastia. Came to your clinic, you were not there, you were on the north coast of Cairo, of Egypt, and your intern saw him. He said, there is no problem. We're going to stop the spironolactone, that's what's causing the gynecomastia, and we'll start you on Trimethoprim, starting at a reasonable medium dose, 50 milligram per day. But what happened is the edema returned and ascites came back. So you're still enjoying yourself in the North Coast, and he comes back to the same intern who increased his dose back to 100 of the Trimethoprim and tell him, you're not eating enough salt, you're not cutting the salt enough, keep cutting your salt. But despite that, there is no response. His wife too, patient's wife, says that he's eating outside a lot, and I'm not sure if he's actually following a low salt diet or not. So his wife kind of put him under the bus here. So what do you think the cause of diuretic failure in this patient who was stable on 200 milligram of spironolactone? Now he is having worsening edema and ascites. We have one response from Dr. Nawaz. The Trimethoprim is not metabolized, it's activated in the liver. So the Trimethoprim is a prodrug. So you give Trimethoprim, you need the liver to convert it from a prodrug to a drug. So there is no liver, there is no diuretic, then there will be no response. So in this patient, using Trimethoprim in the liver patient is pretty much contraindicated because it's not going to be activated. So this patient with which you came from the North Coast, saw what's happening, explained to your intern what's the problem, stopped the Trimethoprim, put him up a Clarinon, both gynecomastia resolved and edema resolved. You can also try amiloride. I love amiloride. I'm not sure how expensive it is in Egypt. So case 4, a 48-year-old lady, primary biliary cirrhosis, diagnosed around a year ago, had portal hypertension, esophageal varices, had bled before and required some banding, 6 months of ascites and edema, and was placed on low salt diet and diuretics. But despite increasing the dose of spironolactone and Lasix, the edema still persisted. Now she's on 300 milligram daily, aldactone, Lasix 80 milligram a day, still have edema, and actually required paracentesis once. Kidney function is good, sodium is okay, it's a little bit low, but fine. She has no proteinuria. My question to you, what should be the next management of this patient? Dr. Nawab want to put up doses. Yes, the recommendation is to increase 400 a day of spironolactone and up to 160 milligram per day of Lasix. Anybody else want to do anything different? Check urinary sodium and potassium. I like that. So that's what actually happened. We went to assess the oral salt intake of this patient. We asked her, are you eating lots of salt? And she said, absolutely not. Never happens. I follow the recommendation. Never happens. All right. And let's put it to the test. We did a 24-hour urine, and 24-hour urine sodium was 150 millimole per day, almost double what we're supposed to eat. We did random urine electrolytes, and the sodium was 22 milliequivalent, and potassium was 14 milliequivalent. So that indicates that she's not compliant with her diet. So what should we do? Is that we have to send her to the dietitian and try to educate her about reading the salt labels, try to educate her how much salt is in a tablespoon of table salt, and try to tell her to use different kinds of seasoning to use with her diet to avoid excessive salt intake. Again, I just want to tell you one thing that I always tell the fellows. God created the kidney so we can eat what we want. If there is a problem with the kidney handling the sodium, we cannot eat what we want. You have to limit the intake. So in this lady, you did cut down her salt, educated her. Her edema has improved, but did not completely resolve. What is the next step you want to do? So diet control was mentioned a minute ago. Serum albumin. Well, for the sake of honesty, people do serum albumin here in the US to manage edema. Twice a week, scheduled serum albumin. But it's going to be very expensive. And according to the ASLAD, it's shown some benefit, but not recommended, mainly because of the cost. So in this patient, what we did is that we reassessed the sodium technique. We educated her on everything, but we want to know if she's still following. And actually, what we found based on the reassessment of the sodium excretion of the urine, that this time she was able to maintain her diet. And in this situation, we said, you know what? Maybe Lasix is not enough for her. Maybe we need something else. We need something long-acting. Furosemide is, yes, furosemide is a better option in this patient, and or Bumex, because Bumex has better bioavailability. Okay, giving the Lasix twice a day will avoid the effect of rebound salt absorption. So in this situation, we increase her salt, we will increase her diuretics and modified it to a different formulation. Torsemide is long-acting. Bumex has better bioavailability. I like torsemide because it's long-acting. It's up to you what you would like to use, but in general, you need to do something different to manage this patient. Last case is the case I copied from an article that I found very informative. 57-year-old gentleman, end-stage liver disease, has worsening ascites, dyspnea, history of hepatitis C, varices, CKD. He's adherent to his medication, which include spironolactone, propranolol, and Lasix. Blood pressure is 102/50. Heart rate is 90. He has tense ascites, distended abdomen, dullness to percussion, lungs is clear, serum sodium is 130, urine is 41, and creatinine is 1.7. Urine sodium is less than 10. What is the next step of action in this patient? Albumin, conivaptan, Lasix, hydrochlorothiazide, or paracentesis. Dr. Manal wants paracentesis. Dr. Mohammed Mustafa wants paracentesis. Who else wants paracentesis? We'll go once. We'll go twice. And yes, the correct answer is paracentesis. So this patient is the end of the road. This patient, he's taking his medication, he's compliant, has tense ascites. More than likely, now is developing the terminal stages, diuretic resistant ascites, or Dr. Huda wants, Dr. Huda al-Maghabi wants paracentesis as well. So that's more than likely what's happening. That's what you need to do. Paracentesis, and call it today, because these people, gonna give them diuretics, it does not work, gonna run into problem with volume overload. Probably the best say is to say this refers them to the liver transplant, if there is a liver transplant program next by, and move forward, because you cannot do more than this. So I presented 5 cases. I just want to do the summary. Hepatic cirrhosis have distinct hemodynamic changes, okay, that all end up with progressive renal vasoconstriction, salt and water retention that leads to edema and ascites formation. Ascites is first, followed by edema. But this is not on and off switch. This is over time, very slowly progressive changes. Diuretics are meant to do natriuresis, and along with low salt diet is the initial or cornerstone in managing water retention, water and salt retention. Potassium-sparing diuretics, because of multiple reasons, are the first line or has to be combined in the first line for management of diuretic in this patient, plus or minus loop diuretics. Diuretic resistance is common and needs to be a stepwise approach that involves you, the blood pressure machine, the lab to monitor the electrolytes, with a scale to monitor the weight, the patient to monitor the food labels, and education from dietitians, and online tools like online calculators to tell you how much salt in what diet you're taking. Being familiar with the pharmacology of diuretics is essential for the nephrologist, and you have to understand that at some point, diuretics cause more problems than benefit, and at some point, we have to stop them. With that, I will stop here and wait for any questions in the chat.
Thank you so much, Professor Hani, for this very interesting lecture and for the highly comprehensive review for diuretic use in general, and focusing on the how to use in the patients with liver disease and especially cirrhosis, and for very interesting cases. You illustrated the pathophysiology of hepatic cirrhosis and how edema develops in this situation. Difference between various types of diuretics used, and especially the pharmacokinetics of diuretics and the pharmacokinetics, and how to translate this into pharmacodynamics and doses. Coming into clinical applications, SAG importance and cutoff points of 1.2 and 2.5, how to use different types of diuretics, especially in liver disease, and you went somewhat through SGLT2 inhibitors as their side action as a diuretics. Also diuretics goals in cirrhosis. How to use combination diuretics in cirrhosis, and the importance of salt restriction, importance of assessment of urinary sodium and sodium-potassium ratio, which is very important to judge if there is dietary incompliance or diuretic underdose, and also albumin use in liver disease and in cirrhosis and in ascitic patient, which is a very important point, and you have asked about this through the lecture, but you answered it, and so you will not find the question because the doctor removed this question because you answered through your question. Also oral and IV diuretics, when to use oral and IV diuretics, and finally the diuretic resistance. And thank you, how to address the resistance and how to address types. Also, very, very interesting cases and the application of your mentioned informations. And thank you very much. And before I go to some questions, I would like to thank our coordinator today, Dr. Hazim Abu Shusha, who is a nephrology specialist in the Manhoor Specialized Nephrology Institute. And thank you for all of his work in CME chapter of Egyptian Society of Nephrology and Transplantation. Please, Hani, you have many thanks on the chat. And I have a question. I can see that your time is limited with work. So I have a question. You said that usually creatinine rise before edema, after edema mobilization. And this is what you find in your practice. But I think in our practice, we find usually that creatinine starts to rise early before any clinical response regarding edema. Do you have an explanation for this or this interpretation?
Yeah,
from us?
so there's many things that can raise the creatinine, okay?
Yes.
So my policy is somebody with elevated creatinine, I look at the patient. If the patient has edema, if the patient has no edema, I'm sure that this patient is probably intravascular depleted. Okay? With the rise in creatinine. If somebody has edema, I don't know what his intravascular status is. I'm sorry, my son just needs me back. 1 second. I'm sorry, it's just my son needs me badly, okay? So what I'm saying is that somebody has edema and rising creatinine. It can be anything. It can be interstitial nephritis, can be pre-renal, can be anything and anything. You so need to re-investigate this. You have to assess the intravascular volume of this patient. So edema is one thing, but intravascular volume is another. The kidney does not see the edema. The kidney sees the intravascular volume. So we mentioned this before. I did not want to allude to it. Things that can help you assessing the intravascular volume: jugular venous distension, chest X-ray to look for pulmonary edema, echo to look for the IVC diameter, bedside ultrasound to look for the IVC diameter and the collapsibility. Okay, all these will help you. The recommendation by the guidelines is that if somebody who's rising creatinine, even if they have edema, you can give them albumin, okay, and see what the albumin will do to you. If the albumin causes improvement in kidney function, then that's a good thing. That means that this patient was probably intravascular depleted and needed some fluid to keep perfusing the kidney.
Thank you so much for the response. A question from Dr. Muhammad Abdel Bari is asking about frequency of paracentesis you recommend a specific frequency, or how can you assess?
Most patients will start with. Most patients will. What will happen to them is that at time of diagnosis, they will show up with ascites and all these things, and they don't know what's happening. So they will have one paracentesis at a time. Then they start on diuretics, and if you adjust the doses and keep them fine, they will not need paracentesis for months, for maybe years. Then, as the liver disease progresses and they're becoming more and more terminal, then the paracentesis become a problem. Some of them will need it once a month. Some of them will need it once every 2 weeks. One of them will need it every week. And people sometimes need it every 2 weeks. So the frequency of paracentesis is dependent on how fast the patient accumulates the acidic fluid. If he cannot handle paracentesis once a week, then you have to do it twice a week. The more terminal the disease, the more frequent the paracentesis requirement. It's not a good sign. I noted too one thing, that patients who have a liver transplant, if they develop ascites after a liver transplant, that's always a very bad signal. And many of them will end up with acute kidney injury. So post-liver transplant ascites is a very bad sign. Many times is a risk factor for acute kidney injury in these patients.
Thank you. The last question from me, you said that to stop diuretics or decrease the dose when creatinine rise. Stop diuretics, you said. Creatinine rise, is there any specific level? Do you at that level you start to move and adjust your diuretic dose for creatinine rise or decline? For example, similar to what occurs in GFR decline after ACE introduction or something like this. Do you have clear cuts for creatinine level that you move to adjust your diuretic dose when it reaches?
If it reaches the level I am not comfortable with. So acute kidney injury is rise with a creatinine of 0.3 or higher, right? 1.5. So depending on creatinine, that's a tricky, this is a topic on its own, because the creatinine in a 60-year-old female of 0.9 is totally different than the creatinine of 0.9 in a 25-year-old young gentleman, even if both of them have hepatic cirrhosis. So creatinine itself is not the best indicator, but it's available indicator. Change delta creatinine is a good indicator. So the delta creatinine acute kidney injury is defined 0.3 milligram rise or 1.5 time rise of the delta creatinine. I think this is the minimum stage of acute kidney injury, which is stage 1 acute kidney injury. So it depends on your comfort level. Again, there is no test that tells you the whole story. Creatinine alone is not going to tell you the whole story. You have to combine creatinine with blood pressure, with clinical examination as far as edema is concerned, and you come up with a treatment plan, because creatinine alone is not the only thing. Most of those patients will have no kidney disease per se, but I have seen patients that creatinine is rising because they have diabetic nephropathy. Okay. And it's not the liver disease that drives or the diuretics that drives the rising creatinine. It's the original disease that drives rising creatinine. So to answer your question, people say, our old teaching say, above 1.5, cut it down. Okay. But this has changed to acute kidney injury stage 1. So anybody who has acute kidney injury stage 1, you probably need to scale back the diuretics a little bit.
Okay, thank you.
You're not gonna hold it for a couple of days in everybody.
So it's
Those-
personal.
The patient I presented, her creatinine increased from 0.9 to 1.6, and she became hypotensive. This one, I will hold the diuretics for a couple of days. But assume the creatinine increased from 0.9 to 1.2, and she's not hypotensive, I will just scale back the diuretics and see what happens without holding it for a couple of days.
So you personalized your response, and finally you take your judge about the arrival criteria, 5 stages of kidney injury, starting from the risk stage. Thank you for your response. Thank you, Professor Hani, Wadei, for this very interesting session and very long session. We really approaching 2 hours, and this was very interesting in lecture, very informative, full of informations, and is a good reference to be for all postgraduates and for how to use diuretics in general and how to use diuretics especially in liver disease. Thank you so much, and for your oral response to all questions, and for your nice presented cases and discussion with the audiences. And excuse me to close this session, and thank you for all the attendees and for all professors who shared us. And excuse me to close this session, and hope to meet you again in the coming sessions of Egyptian Society of Nephrology and Transplantation CME chapter meetings. Thank you.
Thank you. Thank you for the invitation. Thank you for everybody who attended. And we'll hope to meet you again in person or virtually. All right?
Thank you. Yes.
Thank you.
Big great opportunities. Thank you, Professor Hani. Thank you. And meet you soon, hopefully. Thank you so much.
Thank you.